going to discuss a new chapter, clinical chemistry. You know, there are four main departments of the clinical laboratory. These are clinical chemistry, hematology, microbiology, and blood banking. That means the first main department or branch of the clinical laboratory is clinical chemistry, which is my specialty. I can talk about this chapter a lot, but I am going to summarize for you guys and simplify it as I can. Now, the clinical chemistry is the area of chemistry that is generally concerned with analysis of blood or other body fluids for diagnostic and therapeutic purposes. And this kind of area change continue to occur because of the introduction of a new methodology and increasingly sophisticated instrumentation. Okay, we usually encounter a new sophisticated instruments when we work in a clinical chemistry. Now, in this chapter, I am going to discuss the clinical, the classic manual methods and also analytical approach currently in common use. Now, as I said, I am going to give a introductory information, what we are doing in the clinical chemistry, for which purpose, and then try to share. Okay. Now let's get continuing with. Okay. And the clinical chemistry, we are doing a lot of tests, and you may know, you may be familiar with some of them. Now I am going to start with the most common test that we are doing in the clinical chemistry is glucose. Now, you know, glucose, I am sure, is a primary source of energy for most body cells. And there are some hormones related to the metabolism of the glucose. The first one is insulin, a hormone secreted by pancreas, beta cells after a meal, and response to high glucose levels. Okay? After a meal, the level of the glucose in bloodstream increases, and which trigger the secretion of the insulin from pancreas, and this kind of hormone, insulin, promotes glucose entry into the cell, and so in order to lower the blood glucose level. And glycogenesis, you may remember from the 1230 biology classes, and glycogenesis is the conversion of glucose for storage as a glycogen. Okay, if you have excess amount of glucose in your body, this glucose mainly converted to glycogen, and mainly in the liver for future energy sources. And glycogenolysis is the breakdown of the glycogen. If needed, the storage form of glucose, glycogen, will break down, converted to glucose, and sent out from liver to the muscles and other tissue for as energy sources. Now, I'm going to, can you see my screen?
Yes.
Okay. Now, these diagrams show the metabolism of glucose as a summary. Okay. Okay. Once the level of the glucose elevated, which we call hyperglycemia, and these will be as a stimulus for pancreas. There are two main functions of the pancreas, exocrine and endocrine. Endocrine function of the pancreas produce and release hormones. Okay, glucagon, insulin, and some other hormones. Okay, now once the glucose elevated in blood will stimulate pancreas, and then pancreas, beta cell of the pancreas will produce and release insulin. Insulin will, okay, decrease the blood glucose and okay, bring them in a normal glucose range. Okay, once the glucose is too low, below the normal range, which you call hypoglycemia, now is again stimulate pancreas, but this time not beta cells, alpha cells. Okay, and these alpha cells, okay, we produce glucagon and release the glucagon other hormone. This glucagon will increase the blood glucose levels. Okay, now I want to be sure whether, okay, okay, I am in the correct one. I may, let's see, I may go on. Okay, okay. Okay. Okay, this diagram is also about the metabolism of the glucose, but a little bit in detail. Now, as I said, hyperglycemia, okay, or high blood sugar, okay, promotes insulin release from pancreas, and insulin will stimulate glucose uptake from blood into uh, the tissue cells. Okay, that means it will decrease the glucose. It also stimulate glycogen formation in the liver. Via this true way, okay, stimulation of glycogenesis, okay, and stimulation of uptake of glucose into tissue cells will decrease the glucose levels. Okay, if you have low blood sugar, hypoglycemia, which promotes glucagon release from pancreas, and glucagon will stimulate glycogen breakdown, glycogenolysis, okay, and then send out glucose from liver in order to regulate the blood glucose level, to increase it. Okay, hyperglycemia is defined as increased blood glucose level above 126 milligram per deciliter. Hypoglycemia is defined as blood glucose level less than 50 milligram per deciliter. Okay, now diabetes is associated with the level of glucose, and maybe one of the most important disease. The incidence of diabetes in the US is about 8.7%. Okay, these slides actually show us the importance, the medical importance of the diabetes. Okay, we know that currently about 80.8 million persons have been diagnosed with diabetes, and unfortunately 7 million are estimated to have disease but are undiagnosed. Okay, the undiagnosed diabetes result in a complications, okay, damage of kidneys, neurons, or eyes, okay, which means that we will be too late to manage such kind of disease because it is undiagnosed. Okay, there are, okay, considerable racial and ethnic differences in diabetes. Okay, but and there are a complication of diabetes. Okay, these are really important. If you don't manage diabetes earlier, okay, you will see some kind of complications as a heart disease or stroke, or also the diabetes is associated with long-term damage, including failure of organs such as eyes or kidneys or neurons. Nephropathy, neuropathy, okay, or some damage in our eyes. Now, there are two types of diabetes, type 1 and type 2. Type 1 is also known as insulin-dependent diabetes and results from cell-mediated autoimmune beta cell destruction. Is this kind of autoimmune disease, usually leading to total leading insulin deficiency. What does means you have to replace insulin. You have to these kind of patients, they have to administer insulin daily or twice or three times a day. Now, okay, what happens if you have a insulin deficiency? Okay, insulin promote glucose entering into the cells, and glucose is a first and main energy sources for tissue cells. Okay, if you have a insulin deficiency, even though you have enough glucose in your blood circulation, but this glucose is not able to enter into cells for energy sources. And then your body will break down fat, which we call lipolysis, from adipose tissue to supply energy in diabetes, which can be life-threatening. Why it is life-threatening, I am going to explain them. Because increased lipolysis result in increased concentration of ketone bodies, okay, which lead to ketoacidosis. Ketoacidosis will change the pH of the blood, okay, which is really crucial, really essential. and life-threatening, because if you change the pH of the body, the blood, okay, it will destroy everything. We know that the blood pH is between 7.35 and 45. It's tightly regulated during, if you have high concentration of ketone bodies. These are acidic molecules, and they will make the pH acidic, and it will affect the enzyme activity, metabolic pathways. Okay, and it is really important. Now, type 2 diabetes, the other type of diabetes mellitus, is also known non-insulin dependent diabetes. And it's characterized by insulin resistance and progressive hyperglycemia. Even though you have enough insulin secretion, however, this insulin you have insulin resistance. This insulin is not effective, okay, because of some other problems, okay, such as obesity or low level of the receptors, okay, or restriction of the receptors, because insulin should bind to its receptors and then become effective. Okay, now the risk of the complication in type 2 diabetes are atherosclerosis, okay, increased coronary artery disease, and cerebrovascular accidents. However, these kind of complications, they develop gradually, okay, within decades, and usually type 2 diabetes diagnosed after age of 40 or 50, and this complication will develop after age of 40, 50, and then if you don't manage the type 2 diabetes, and this kind of complication will also be life-threatening. Now, okay, the risk factor for type 2 diabetes are several, as you see some of them here: high body mass index, family history of type 2 diabetes, race, ethnicity, okay, sign of insulin resistance or conditions associated with insulin resistance, such as obesity, okay, maternal history of diabetes or gestational diabetes mellitus. These are a risk factor for diabetes, type 2 diabetes. Now, the traditional classical symptoms of diabetes are polyuria, hyperglycemia, okay, and glycosuria, means the excretion of glucose via urine, and polydipsia, okay, drinking too much water, okay. Polyuria is high frequency of urination. You may know these definitions, this terminology. In acute episodes of the diabetes, blood ketones, which if you have high blood ketones, we call ketonemia, and urine ketones, high amount of ketone in the urine is known ketonuria. These are maybe an acute episode of the diabetes due to the ketoacidosis or ketonemia. Now, how we diagnose diabetes? Okay, since this is a common disease, about 8.3%, in some countries is more than 10, 12%. And there are as you see here, um, several criteria uh, for diagnosis of diabetes. A hemoglobin A1C, uh, fasting blood glucose, 2 hours plasma glucose, and random glucose, plasma glucose. Okay, any of the following indicates diabetes. If hemoglobin A1C greater or equal to 6.6%, or fasting plasma glucose is equal or above 1.26 milligram per deciliter, or 2-hour plasma glucose greater or equal to 200 milligram per deciliter, and random glucose, plasma glucose greater or equal to 200 milligram per deciliter. Okay, any of these help you to diagnose diabetes. Okay, if you use one of them and get the result as we see on these um, slides, you can diagnose the patient as a diabetes mellitus. Now, okay, pre-diabetes, okay, or increased risk for diabetes mellitus is also known pre-diabetes, and these are criteria to diagnose patient as a pre-diabetic patients. If hemoglobin is between 5.7, 6.4%, or if fasting plasma glucose between 100 and 125, or 2-hour plasma glucose is 140, 199 milligram per deciliter, and so on. Now, these tables summarize the diagnostic criteria of diabetes and prediabetes. Okay, you may review them later. Okay, now the other type of diabetes mellitus is the gestational diabetes mellitus. Okay, the classic diabetes is uh, classified as type 1 and type 2. Okay, however, we have also other type of diabetes such as gestational diabetes mellitus, is defined as glucose intolerance that is first diagnosed during pregnancies. Okay, this is a kind of glucose intolerance. Okay, a dysfunction of glucose metabolism. Okay, and a current hypothesis about gestational diabetes mellitus is that placental hormones block the action of a mother insulin in her body, called insulin resistance. Okay, they created a insulin resistance, and which, okay, result in gestational diabetes mellitus. Okay, uh, diabetic patients can be pregnant and delivery a healthy babies. Okay, diabetes itself, if it's managed, if it's controlled, is not harmful for the babies. Okay, uh, okay. Now, a high maternal blood glucose levels uh, in the gestational diabetes mellitus, okay, uh, make the fetus pancreas secrete more insulin, and fetus receive more energy than needed and becomes a fat, okay, overweight fetus, which can lead to shoulder injuries at birth during the normal delivery. After birth, then the newborn maybe have very low blood glucose levels because it has already a high insulin concentration, and then after birth, the baby cannot provide enough glucose, and insulin will decrease the glucose. Sometimes it will be life-threatening if hypoglycemia is too low. Okay, and also the babies of the gestational diabetes mellitus patients, they may have at risk for breathing problems. Okay, the lungs, they are not enough mature, and then they may some have breathing problems. Okay, how we diagnose gestational diabetes mellitus? Okay, screen for gestational diabetes mellitus at 24, 28 to 28 weeks using a 75-gram dose of glucose for oral glucose tolerance test. You upload 75 gram of glucose, and first you withdraw blood, fasting blood. If it is greater than or equal than 92 milligram per deciliter, you can diagnose as a gestational diabetes. Or after loading of glucose orally, then you withdraw blood after 1 hour and 2 hours, okay, and then get a diagnosis of the gestational diabetes mellitus. Okay. What we can do in terms of screening? Okay, it's maybe your patients seems like healthy patients, but for females who are planning to get pregnant, you have to do a screening test. Okay, screening women with gestational diabetes mellitus for persistent diabetes, 6 to 12 weeks postpartum, using oral glucose tolerance test. I'm going to explain it later, and non-pregnancy diagnostic criteria. Okay, and continue to screen women with history of gestational diabetes mellitus for diabetes or pre-diabetes at least every 3 years. Okay, and women with gestational diabetes history should receive lifestyle interventions and or metmorphine for diabetes preventions. Okay, if you diagnose gestational diabetes mellitus, you have to screen the patients after 6 or 12 months after postpartum, and you also have screen every 3 years, and you also provide lifestyle interventions or metmorphine for diabetes preventions. Okay, what we can do as a preconception care, okay, maintain hemoglobin A1C levels as close below 7%, okay, as possible, and provide preconception counseling and evaluate and treat in women contemplating pregnancy if it is necessary. Okay, the risk of diabetes mellitus or gestational diabetes mellitus, the most common risk or complications are nephropathy, okay, damage of the kidneys, neuropathy, damage of the neurons, and cardiovascular diseases. Okay, as a pre-conception care, before the female get pregnant, you have to evaluate the patients and consider risk and benefit of the medication used prior to conceptions. Okay, it can use these kind of the medicines uh, uh, prior the conceptions, but during the pregnancy, these statins, angiotensin converting enzyme inhibitor, or angiotensin receptor blocker, and most non-insulin therapies are contraindicated and not recommended in pregnancies. Okay. Okay. Now, other cause of hyperglycemia, which we call secondary uh, hyperglycemia, can be due to traumatic brain injury or febrile diseases, certain liver disease, or overactivity of adrenal, pituitary, and thyroid glands. Okay, the, the overactivity of other glands, such as adrenal glands, pituitary gland in our brain, and or thyroid glands, they also may cause diabetes mellitus, okay, which we call secondary hyperglycemia. Okay, stress-induced hyperglycemia in patient of severe illness is also important. Okay, a patient with multiple organ damage or multiple fracture, okay, or a big surgery, after big surgery, which are stress full intervention, okay, they may cause hyperglycemia, and we call stress-induced hyperglycemia. Okay, hypoglycemia, if the level of glucose, blood glucose is below 50 milligram per deciliter, is known as hypoglycemia. Okay, and it can lead to nausea, vomiting, muscle spasm, unconsciousness, and death. Okay, acute um, acute decreases of glucose is um, dangerous than hyperglycemia, because we know that the single source of energy of our brain is glucose. During the hypoglycemia, the brain tissue will affected primarily and first. Okay. Okay. Other causes of hypoglycemia can be glycogen storage disease, islet cell hyperglycemia, or insulinoma, which is cancer of beta cells, uh, and most common cause in neonates or uh, prematurity maternal diabetes, okay, uh, gestational diabetes mellitus, or maternal toxemia, other kind of disease during the pregnancy we see. Uh, these are okay, most common cause in neonates are prematurities. Okay, okay, maternal diabetes or gestational diabetes mellitus and maternal toxemia. Okay. Now, there are a few tests uh, to diagnose diabetes mellitus. Glycemic markers, as I told you before, hemoglobin A1C. We are using this test both diagnose and monitor diabetes mellitus and use it for, okay, it can estimate glucose control over the preceding 2 to 3 months. And we also have a emerging glycemic biomarker. These are fructosamine and glycoalbumin. They can estimate glucose control. Okay, um, and as we see, glycoalbumin is based on the half-life of the serum albumin, which is about 20 days. Okay, and what does means? Okay, uh, it can um, uh, okay, give a estimation glucose control over the preceding uh, 2 to 3 weeks. Okay, the first one, and glycemic biomarker hemoglobin A1C, is give us a um, information about glucose control in the past 3 months, okay, 2 3 months. However, uh, the glycoalbumin or glycated serum protein and glycoalbumin ratio, it give us the last 2 3 weeks. What does means, if you diagnose the patient as a diabetes mellitus, and then you will start with medicine, right? An intervention, and you want to monitor this patient, see the effect, whether your treatment is effective or not. Okay, you don't need to wait 3 months or 2 months. Okay, after 2 weeks, 3 weeks, you can measure glycoalbumin and calculate glycolated serum to the glycoalbumin ratio, and then see whether your treatments is effective or not. Okay. Okay, collection of blood specimen for glucose. Okay, there are three sources, as you know, from the phlebotomy chapter. Capillary blood specimen, uh, maybe one of the most common one, venous blood specimen, and type of blood specimen type. Okay, the blood withdraw after 8 to 12 hours fasting, or you can withdraw after 2 hours after a meal, okay, which is known postprandial uh, glucose levels, okay. Um, okay, other body fluids glucose, we can also can measure the level of glucose in cerebrospinal fluid or in urine. Okay, point of care testing for glucose, most common point of care test, and the first um, um, test, which is uh, the first test, uh, which is uh, uh, okay, uh, allowed to use by the FDA, okay, and the first point of care test, okay. Generally we using a capillary blood, okay, by a finger puncture, as I showed you before, uh, and then uh, get a drop of blood and measure the glucose levels, blood glucose levels. Okay. Okay, the methods for qualitative or semi-quantitative determination of glucose are several, and most methods for quantitative determination of glucose. There are two common methods, uh, glucose oxidase methods and hexokinase methods. These are enzymatic methods that we are most of the test procedure are using one of these enzymes to measure the, the level of the glucose, the concentration of the glucose. As you see, this is an example for hexokinase methods. You put, I mean, you put, okay, you put a patient blood in a test tube and add a reagent which contain ATP, okay, uh, and then hexokinase enzymes, and the will hexokinase will convert glucose to the glucose 6-phosphate. In the second step, you add an NAD, okay, nucleotide adenine diphosphate, and glucose 6-phosphate dehydrogenase, other enzymes, and then you will create 6-phosphogluconate and most important NADH. This is reduced NAD, and this will change the color of the tubes, and you will measure the color of the test tube at 340 nanometer and get the result of the glucose. This is an example how we measure the glucose enzymatically, the method of the glucose measurements. Okay, these are a reference glucose reference values. As I mentioned before, they may change between adults and children. Uh, okay, the total blood in glycated hemoglobin A1C should be less than 5.7%, and the cerebrospinal fluid should be 2 in 3 um, uh, ratio in the cerebrospinal fluid. If let's see if you have a blood circulation glucose 80 milligram per deciliter, okay, 2 in 3, what that means, okay, the cerebrospinal glucose level is supposed to be around 60 milligram per deciliters, okay. The CVS glucose is depend on the blood glucose, okay. And then you have to know, we have to measure both blood glucose and cerebrospinal fluid glucose in order to um, interpret the result, whether the cerebrospinal fluid glucose is normal or not. Okay, other laboratory tests for diabetic management, blood glucose, or hemoglobin A1C, ketone bodies is important if you think that patient has a type 1 diabetes or acute hyperglycemia of type 2 diabetes. Okay, these are ketone bodies, acetone, acetacetic acid, 3 beta hydroxybutyric acids, 3 type of ketone bodies that circulating in the blood of type 1 diabetes or acute hyperglycemia. If we have the glucose concentration above 600 milligram per deciliters, probably you will measure ketone bodies in blood. Okay, microalbumin, other test that we monitor diabetes patients. It is powerful predictor for future development of diabetic nephropathies. You can earlier diagnose nephropathy, okay, before a big damage of the kidneys, okay. Therefore, we are using microalbumins, okay, as a predictor of diabetic nephropathy. Okay, now I am going to finish with these questions. I have a few questions here for you guys, and then we will finish for today. Now, okay, which of the following tests are used to diagnose diabetes mellitus? Okay, now your turns. Sodium, glucose, creatinine, hemoglobin A1C, glucagon. Okay, go ahead and send your responses. Just I'm waiting. One more. Okay, there are two correct answers here. You have to choose. Okay. Thank you. Okay, glucose and hemoglobin A1C. Okay, two of them correct. Okay, you can, I mean, for diagnosis, one of them will be enough, however, but these are diagnostic tests. Also, you can monitor the diabetes with these tests. Okay, now, okay, next one. Which of following is not a classic symptom of type 1 diabetes? Polyuria, polydipsia, polyphagia, proteinuria. Is not classical symptoms of diabetes mellitus. One more. Polyuria, polydipsia, polyphagia, proteinuria. Okay, thank you. Now let's see. Okay, the D is correct. Proteinuria is not a classical symptom of diabetes mellitus. Others are. Okay. Others are the symptoms, the classical symptoms of diabetes mellitus. Okay, good. Now, let's see. Next one. Which of following organs stored glucose as a glycogen for later use? Kidney, liver, pancreas, intestine, thyroid. Okay. Produce glycogen and store it for future. Okay, thank you. Okay, liver is the correct answer. Okay, liver produce glycogen, convert excess amount of the glucose to glycogen. Okay, for future use, and then later a liver can break down the glycogen to produce glucose, send out the glucose to brain, to muscle, other cells. Okay? Okay, now, okay. Which of the following is not the risk of complication of diabetes? Okay, complications of the diabetes mellitus: atherosclerosis, nephropathy, neuropathy, cerebrovascular accident, and cancer. Okay. Okay. Okay, cancer is the correct answer. Okay, other are the complication of the diabetes. Atherosclerosis, nephropathy, the damage of kidney, the damage of the neurons, okay? And cerebrovascular accidents, this is due to atherosclerosis, okay? But cancer is not a complication of diabetes, right? Okay. Okay, that should be enough for today.